which is the section on interactive cases. I'd like to introduce, if I may, Yvonne Cartwright, who is a consultant in palliative care medicine at Adam Brooks Hospital and a passionate advocate for patients with liver disease, and Fiona Smith, who is a specialist nurse in hepatology at Adam Brooks and who works with Yvonne to deliver the enhanced supportive care service to patients with end-stage liver disease. They've worked very hard over the last few years to develop that service, and we really look forward to this presentation this afternoon about the care of patients in need of palliative care.
Thank you very much for the invite. We're going to start talking about a patient, and then we're going to talk more broadly about the palliative care issues for this group of patients and how we're trying to ensure that they get their needs met.
So this is a case study of a patient that I've been seeing in the stable cirrhotic clinic for many years. Patient is DH. He is age 73 with type 2 diabetes, ischemic heart disease and COPD. He's got NASH cirrhosis with portal hypertension, which was diagnosed in 2011. From 2014 to 2018, he had his usual 6-monthly cirrhosis surveillance, which had all been stable. However, in May 2018, he had evidence of decompensation. He was found to have moderate ascites on his scan, bilateral leg edema, and we started some spironolactone, ciprofloxacin, and had monthly reviews from this point. He then ended up having to have weekly paracentesis. So until from May until September 2018, he was having these coming in weekly, and I was draining him. And then into September 2018, it became apparent that he wasn't going to improve and his liver disease was deteriorating further. So I had a discussion with him, and we spoke about having an indwelling drain inserted. And at that point, he was referred to the enhanced supportive care team. At the enhanced supportive care appointment, he was commenced antidepressants for a low mood. He was supported to claim PIP, encouraged to update his will, and referred to the community palliative care team. We reviewed his support in the advanced liver disease MDT in April 2019, and everything was in place. Unfortunately, he died in May 2019, but without readmission to an acute trust, and he was at home, and his wife was with him when he died.
So what we know about end-stage liver disease is that the mortality rate from this in the UK is rising rapidly, which is in marked contrast to other disease etiologies, and that also the mortality increases in adults of working age, which again is unique. Patients with advanced liver disease have a symptom burden comparable to cancer and other life-limiting conditions, and that there are significant social issues with the overlap between financial hardship and psychological distress for patients and carers, and we know that an early MDT is helpful. I think the unpredictable trajectory of this disease makes prognostication difficult, and also there is the fact that often very acute treatment is appropriate whilst palliative treatment is continuing. About 70% of patients with advanced liver disease die in hospital. That's much higher than other chronic diseases. Specialist palliative care input for patients with hepatocellular carcinoma and end-stage liver disease has been shown to encourage advanced care planning, reduce in-hospital deaths and reduce healthcare costs. And there is still a significant increase in the number of patients with HCC who get palliative care input compared to those with a non-malignant etiology of their liver disease. And in terms of those who get care in hospices, that difference is much more marked.
So what are the perceptions of hepatologists? They feel that palliative care is sometimes more suitable for those with cancer than without. They do feel that they should have initial conversations about advanced care planning though, but are sometimes unclear about referral criteria for specialist palliative care. Some may be uncertain about the appropriate medications for symptom control, and some still believe that palliative care is synonymous with end-of-life care. We feel that palliative care involvement is inappropriate for patients still being considered for transplantation. It's still a topic for discussion. What's the role of the hepatologist? Firstly, recognition of decompensated cirrhosis and early consideration of appropriate treatment options. Is liver transplantation feasible? But if it is, then what we can do then is it enables us to have a discussion about prognosis, and then palliative care can be involved in parallel with being on the transplant waiting list. If transplant assessment is not, then early discussion about the stage of disease and prognosis should be spoken about. And this can lead to planning and management of decompensation events, giving family and carers and GPs knowledge of how and where to deal with these. Offer of early palliative care input should be given, timely referral to specialist palliative care, or either hospital or community-based. And as I said, timely conversations about treatment escalation plans, including CPR, admission criteria if appropriate, and preferred place of care and death.
So what we ended up trying to produce was a kind of three-pronged approach where we identify appropriate patients, we assess their needs, and we plan for the future. There are different ways of identifying patients who might be appropriate for palliative care. The one we tend to use on the hepatology ward here is the gold standards framework, proactive identification guidance. And it looks for general indications of decline and starts by asking the clinician if they would be surprised if this patient were dead in the next year. If they wouldn't be surprised, then we start thinking about whether they might be appropriate. So there are general indicators of decline, and then the liver-specific indicators: refractory ascites, encephalopathy, malnutrition, hepatorenal dysfunction, bacterial infection, recurrent bleeds, raised iron, hyponatremia, and untreatable HCC. We also, this criteria also includes those deemed ineligible for transplant, because we know that those patients have a significant mortality within the 3 months after their transplant assessment. There are other tools which you'll see written about in the literature. The SPICT is the Supportive and Palliative Care Indicator tool, and there's an app that you can use for this. Again, the liver-specific indicators are very similar. And the Bristol's prognostic screening tool is also very similar. A recent review showed that there wasn't really a benefit of using one tool rather than the other, and also of interest that there wasn't really a benefit in using a tool if you had an experienced clinician who could look at the patients that they were dealing with and decide whether they were suitable. And certainly within Addenbrooke's, that's what we tend to do. I have a board round on the liver ward once a week, and we review all the inpatients, and those clinicians looking after them think about where they are in terms of these screening tools, whether they would be appropriate for palliative care, and then they would go and have the initial discussion. In terms of the assessment, symptoms needing assessment commonly include pain, breathlessness, muscle cramps, sleep disturbance, depression, anxiety, fatigue, and erectile dysfunction. I would probably add itch to that as well. And the way that we assess those symptoms in clinic is via the IPOS, which is a patient outcome scale that we use for cancer patients. Different groups use their own form. The renal clinicians have their own specific IPOS, which look specifically at the symptoms experienced by renal patients. They're asked to rate symptoms on a 5-point scale as to whether symptoms are not at all, slightly, significantly, severely, or overwhelmingly. And what we found is that those scores are fairly reliable, though often when you ask patients to fill in this themselves, it become apparent that a symptom that may seem mild is actually having a very significant effect on these patients. We also ask them how well informed they feel about their illness and their involvement in management plans.
So some of the decompensation events that can be managed without hospital admission, I'm just going to have a quick chat about those now. So the first one is management of ascites. So as you know, 60% of patients with cirrhosis develop ascites, and those with refractory ascites have a median survival of less than 6 months. Day-case paracentesis is known to reduce healthcare costs and days spent in hospital, and leads to reduced risk of dying in hospital. Indwelling drain and alpha pump have similar safety profile to large volume paracentesis and are well evaluated in terms of health risk versus quality of life. We, our team here, our plural team, who we work very closely with, are currently doing a study into complications of indwelling drains, which we should have by the end of the year if anybody's interested. And I know that Basel has done a study, which hopefully everyone should know about.
And to advocate for my community palliative care colleagues, what they would find extremely helpful from hepatologists is to some guidelines as to how long HAS replacement should be discontinued, and that when patients are very end stage, is there a point at which we can switch to just symptomatic drainage via the drain and not needing to replace with HAS.
So we do have frank discussions about stopping HAS replacement and the effect on life expectancy with the patients before we do that. The next decompensation event is management of encephalopathy. It can be very distressing for patients and carers, and they're often aware it's a potential complication of end-stage liver disease until it occurs for the first time. So early education is very vital. It can have a significant effect on health-related quality of life and reduce hospital admissions. So we need to increase the understanding of the condition. We would like to encourage patients and carers to adjust laxatives and enema doses and involve early consideration of the use of rifaximin. Dietitian input is also well evaluated. GPs need educating too, so very often people are admitted with encephalopathy when actually they could have been managed at home.
And there was a study that showed that only 6% of patients or carers knew they were on treatment for hepatic encephalopathy or how it worked.
So malnutrition, optimising nutrition can improve cognition and quality of life in HE. Early dietitian involvement is likely to be helpful, but we are mindful of staffing issues within the dietitian team. But all members of the multidisciplinary team should be able to give simple advice, such as the role of bedtime snack.
In terms of symptom management, there is a specialist interest group in supported and palliative care running with Basel, and they recently produced some very pragmatic symptom control guidelines which deal with how to control pain, breathlessness, constipation, anxiety, agitation, depression, and they are appropriate for adult patients with child Q, B or C cirrhosis experiencing symptoms. I think the main take-home messages are to avoid oxycodone as the half-life is tripled in liver impairment. And that fentanyl or alfentanil are probably the subcut opioid in the last days of life in coexistent renal impairment. But those guidelines are freely available and I'd recommend them to you. When we're thinking about planning, we ask patients to identify advocates. Given the very low understanding of the nature of hepatic encephalopathy, often people haven't considered that at some point they may lose the ability to make decisions for themselves. And it's very difficult for people to make a plan that will cover all eventualities. So what we tend to focus on is encouraging them to identify someone who will be able to speak to them and then to have ongoing discussions with that person about what their priorities are. We talk to them about wishes regarding CPR, treatment escalation, hospital admission, and I've found the RESPECT paperwork quite helpful with that process. But it is important that patients and families are aware of an uncertain trajectory and that a very sudden death can be something that happens with this group of patients. The patient that we mentioned at the beginning died one day after coming to hospital for an indwelling drain. We also ask about preferred priorities of place of care and death, and also make it clear that while people may have certain preferences, we can't always guarantee to meet those and that people need to identify B plans. We also particularly ask about patient and carer preferences around personal care, and particularly for those patients whose next of kin may still be working or may have adult children, and people have very different views on what they're happy for different people to perform for them or not. We ask about their preferences for surveillance endoscopies. We ask about HCC screening, how they would like an SBP treated, are they willing to come and spend 2 weeks in hospital for antibiotics, or would they prefer not to do that, and how they would prefer encephalopathy to be managed. It's very much the case that patients prefer to have these conversations with clinicians they know and trust, and that parachuting palliative care clinicians in to do this doesn't tend to work as well as people who are looking after those patients being willing to have these conversations. These are a couple of interventions that have been evaluated. When we were in the process of setting up both the hepatology board round and the advanced liver MDT, I went and visited the advanced liver disease MDT down in Worthing in West Sussex. They had hepatology and palliative care consultants in the MDT, community liver disease nurses, alcohol liaison services and a social worker. And of note, 77% of patients dying of end-stage liver disease in that region had had palliative care input, either having met palliative care teams in hospital, being known to their community service. The other thing that they had that we don't have at the moment is they have an integrated hospital, community and hospice team with health records held on a central database. And we are trying to work out how we do that here, given that we need both links with our local hospice team, which is Arthur Rank, but also given that we're a specialist centre for the region, that we need to have good links with hospices elsewhere in the region. And only 30% or under 30% of patients known to this service died in hospital, which you'll know from the earlier slide is a significant difference. The Royal Free Hospital has palliative care clinical nurse specialists for liver services, and the palliative care CNS works alongside hepatology and hepatobiliary teams. And again, they have a weekly MDT, we have a monthly one, board round and a research and educational role. And that's led to a massive increase in appropriate referrals to specialist palliative care, particularly for those with non-malignant liver disease. The team working in Exeter have an MDT which reviews any patient presenting with a new episode of decompensated liver disease. And again, they have a very broad MDT with involvement of alcohol services and hospice involvement, agree a ceiling of care and discuss with the patient and carer. Like us, that intervention has come about from the Enhanced Supportive Care Sequin, which was piloted by NHS England to try and improve in the main, the services available to cancer patients still having ongoing treatment, but there was really just a few lines in the initial report saying that this service should be available to patients with non-malignant liver disease. And Dr. Mike Allison, who had significant input into this presentation, and I decided this was our opportunity to try and provide this service for these patients. So here are some references. The first one is a kind of roundtable discussion of what might good look like, very useful. PHE England will give you the statistics you might need to let local healthcare decision makers give you some support for your service. The low JTS is about the perspectives of patients, family members and health professionals, and the Brise Bar is a more practical paper. Compass is a pilot trial of an early palliative care, and I'm afraid the phrase early palliative care gets my hackles up. There's no such thing as early palliative care. It's either timely and appropriate or it's late. And most of the time, especially with this group of patients, we are very late. The thing to watch the space for, in the US, they have compared 2 treatment arms of looking at palliative care led input for patients with end-stage liver disease, or a palliative care trained hepatologist led palliative care, and this trial should report in the next year or so, and it'd be really interesting to see how that works. Slight caution when looking at US based trials is in the US you have to de-enlist from active medical treatment to be able to access hospice care, whereas in the UK we have a much more overlapping service. So you need to, if you're looking at US papers, you need to read them with that in mind. I'm very happy to take questions. I think that's all we really wanted to say, but thank you for listening.
Well, that's super. Thank you very much, Yvonne and Fiona, for that really fantastic presentation. I think we're running a little bit behind time, but I am going to kick off the questions actually with the first being that we obviously at Cambridge have a really fantastic enhanced supportive care service because of all the work that you've done, and you referenced a couple of other examples. But can I just ask? I mean, do all centres across the UK have similar services available to them? Bearing in mind that, of course, a patient with end-stage liver disease may well be the one least able to travel to the local centre of excellence.
So I've been part of the special interest group for a few years now, and we have seen membership from most of the specialist centres, and also quite a lot of local hospitals have sent people to that group. So I think it's certainly a very hot topic within the palliative medicine community, with everyone recognising that this is a group of patients that we need to try and make sure we are meeting their needs. So I think it's happening. I think some places will be more aware than others.
Great.